Dr. Manoria is a director of the Manoria Critical Care and Cardiology Hospital from Bhopal, and is also ex-professor of the Gandhi Medical College. Sir, it's a warm welcome for this particular Revolution talk, which is on the atrial fibrillation and stroke prevention and atrial fibrillation. So, sir, before starting our discussion, can you highlight some important points, your written book on a monograph on atrial fibrillation? What is the key messages that you want to drive to
This monograph is basically written to physicians so that they can understand atrial fibrillation, how to assess the ischemic risk, how to assess the bleeding risk, when to initiate the anticoagulants, when to use the newer anticoagulants, and there are many subsets of atrial fibrillation. Each subset is also highlighted. So, it is a very compact book on atrial fibrillation, and each chapter is decorated with highlights, so that if you do not have time, you can just read the highlights and you will be aware of the key issues in atrial fibrillation.
So, definitely sir, atrial fibrillation, as you rightly mentioned, it is one of the very critical disease. It is the commonest arrhythmic disorder worldwide, and you also mentioned that it is at physician level to know about this disease is very important, because diagnosis at first point of contact for the patient definitely is physician level. So, in your practice, have you find that this atrial fibrillation incidence is little bit under detected as per the actual incidences?
If you have sustained atrial fibrillation, it will not be missed by any good physicians, but on many occasions atrial fibrillation is paroxysmal, that may last for seconds, minutes, and some of these patients develop stroke. Previously, when stroke used to be developed and echo was normal, no other test showing any cause of atrial fibrillation, they were categorized as cryptogenic stroke. But now with prolonged monitoring, we know that if you suppose monitor the ECG for 7 days or 5 days, many of the so called cryptogenic stroke are in reality paroxysmal atrial fibrillation, and that has produced this stroke. So, one of the tests before we label any patient as cryptogenic stroke is to have a prolonged monitoring of ECG, and many times you can pick up that paroxysm, because you cannot pick up, suppose somebody does atrial fibrillation 2 minutes, when he reverts to sinuses, he may stroke. So, that is the, but if it is sustained atrial fibrillation, it can be picked up very easily. ECG will show and anybody can diagnose, there are no issues.
So, as rightly mentioned. So, and you also mentioned that stroke is one of the major complications for the atrial fibrillation. So, it remains 4 to 5 times higher chance of a risk of a stroke when the patient has atrial fibrillation.
No, it depends on the cause of atrial fibrillation. Okay. Suppose it is valvular atrial fibrillation, the risk of stroke is 17 times, compared to non-valvular it is 5 times the normal individual. So, if you are having a valvular atrial fibrillation, which is seen in 50% of the Indian atrial fibrillation, the stroke risk is very high, and optimum anticoagulation is mandatory. Whereas if it is non-valvular atrial fibrillation, which is the dominant scenario in the West and not in India, yes, the risk is 5 times.
5 times. Okay, perfect. So, if regarding the prevention of a stroke in atrial fibrillation, so far there is antithrombotic treatment is available, antiplatelets, oral anticoagulants. So, what is your experience as of now, that how usage of this kind of the conventional oral anticoagulants and antiplatelets in stroke prevention atrial fibrillation?
See, if you provide optimum anticoagulation, the risk of stroke can be minimized at least by 2/3 or more. The problem with atrial fibrillation is many physicians are scared of the bleeding complications of the anticoagulants, but they should be well versed with the subject, and then there will be no issue. For example, if you want to initiate an oral anticoagulant, you have to calculate the ischemic risk, means what is the risk of stroke. The CHADS-VAS score is superior compared to the conventional CHADS score, because it is more sensitive. So, all these scores are given in any book or on the net, and it takes hardly 30 seconds to score. If the score is high means if you have 0 CHADS-VAS score, nothing is required, 1 preferably anticoagulant, but 2 or above you have to use anticoagulant. Before initiating anticoagulant, you have to check the bleeding risk, because anticoagulants will be associated bleeding. If they are not associated bleeding, they are not anticoagulants. So, if the bleeding risk, again you can easily check by the Hess-Blood score, and it takes half to 1 minute, very simple score. If the bleeding risk is high, which means this risk of score is, bleeding risk score is more than 3, it is high. Even if the risk is high, it does not mean you should not give anticoagulant, because the benefit is still more than the risk. Most of these patients will die of ischemic stroke rather than bleeding. But if you have a high bleeding risk, you have to take certain precautions. First is, there are many reversible factors for the stroke risk as well as the bleeding risk. You try to minimize hypertension, kidney function, obesity, so many factors. So, minimize ischemic risk and bleeding risk, and then initiate. If you are using warfarin, say because the patient cannot afford, you have to keep the INR between 2 to 2.5, and you must teach the physician and also the patient that very vigilant watch should be kept on bleeding, so that you recognize bleeding at the earliest.
Yes.
Patient should also be told the key point, the physician should also know, so he should periodically check. Of course, INR has to be checked, but sometimes the INR is so fluctuation even after checking, because it is dependent on virtually most of the food items. So, the patient should also be told to pick up bleeding at the earliest. Okay. And with newer anticoagulants, the intracranial hemorrhage, which is very disastrous, is 50% decreased by all the new anticoagulants. Yes. So, if you have a high bleeding risk and you want to use, the choice will be newer anticoagulants, and among the newer anticoagulants is Apeximin, which is the produces least bleeding, provided cost is not an issue. So, high bleeding risk, the first choice is Apeximin. Warfarin is not the choice. It will be used if the patient cannot afford, because warfarin, the bleeding continues for a very long time. The advantage of these newer anticoagulants, their action finishes so soon. Half-life, most of them is very small, so few hours it will finish automatically, and now we have antidotes also. But the issue is, you should try simultaneously to reduce the bleeding and the ischemic risk. Control is hypertension, control is weight, control is renal functions, all these things matter.
So, definitely sir, you have mentioned very correctly that VKs are older and standard drugs, but still they have some practical challenges like INR monitoring, food drug interaction, and their patient has a double-edged sword kind of condition, high risk of stroke and high risk of ICH. And in place of that, the newer generation of oral anticoagulants like Apixaban, Rivaroxaban and Dabigatran, they have a chance to replace this kind of a treatment. So, sir, what is your experience that of these all three NOACs? How can we can put individually in some group of the patients when they atrial fibrillation?
If your relation or friend is taking an anticoagulant like warfarin, you will understand the limitation. What is the problem with warfarin? Always you have to keep the iron between 2 and 3. He is always walking on a tightrope trying to balance the efficacy and safety of the drug. Today is INR 3 point, he goes to a restaurant, takes something, he drinks. Food items, I think there is a big list of the drugs and drug to drug interaction, food to food, there is so many that despite all precautions the INR will fluctuate. And the pharmacokinetics and pharmacodynamics of warfarin are highly unpredictable. Same dose in different individual will produce different effect. Same dose in the same individual will produce different over different periods of time. So, the variable pharmacokinetics, the variable pharmacodynamics, a narrow therapeutic range. If you cross the range above 3, bleeding, below 2, stroke. The third is, because of these dietetic restriction, patient is in a really mess. If he goes for a party, he goes for marriage, he is all the time looking at what to eat, what to not to eat, and despite that things change. And then the action of warfarin is so prolonged that once you bleed, particularly intracranial, it is very unlikely that you will be revived. The problem is the ooze continues for days, and the misnomer is that warfarin can be antagonized by vitamin K. If you use vitamin K intravenously, it takes 10 to 12 hours to act. It is not that IV push and action starts. And even with severe bleeding with warfarin, you have to use the recombinant factor 7 or other thing. Warfarin bleeding can never be controlled by vitamin. In dangerous situation, mild bleeding may stop. So, warfarin has an antidote, but it is overwhelmingly expressed that it has an antidote. It has an antidote even after intravenous administration, it will take 12 hours, and 12 hours the patient will be killed. Even if you give water, it is not going to ooze. And Indians are more notorious for this bleeding. And of course, cost of the warfarin less. There is no doubt that these newer agents are very good. They are criticized, but if you look at what is the variable pharmacokinetics, the newer have predictable pharmacokinetics. One of the most distressing thing for warfarin, lifelong blood testing, go to a pathologist, go to a clinician, again go to a pathologist, again to a clinician. That is not there. The third thing is lot of dietetic restrictions which are not there. Drug to food interaction are non-existent with new agents. Drug to drug interactions are very few, say antifungal agents, AIDS, quinidine, verapamil, amiodarone, but these drugs are not commonly taken by this, not like an antibiotic you will take. So, you should be aware of these interactions, and the biggest advantage is, this greatest sigh of relief is that he has nothing to test throughout his life, food restrictions are not there, and the pharmacokinetics are so predictable, the onset is quick, the offset is quick, the therapeutic range is wide. So, there is no doubt that these agents are superior, and the limitations which are criticized, it has no antidote.
Yeah.
It is automatically the action weans off so quickly, and now you have antidote for dabigatran already approved, antidote for the rivaroxaban going to be approved very soon. But these antidotes are more for fear of the physician or maybe for some of the cardiologists. The action weans off, but still now you can use. And another thing which is criticized, that you do not have any validated test to measure the anticoagulant efficacy. The reality is that they do not require validification of their anticoagulant, because the pharmacokinetics are primitive. Yeah. But this does not mean they will never require. They require if you have renal function, if you are going for surgery, if you have already bled. So, the physician must be well versed as to what precautions. Your renal function is very important, particularly if you are using dabigatran 80% exceeded, rivaroxaban 66%, apixaban only 25%. So, if you have a bleeding problem, you have a kidney problem, apixaban is the drug. And the misnomer for warfarin is, warfarin, the recent Canadian meta-analysis of more than 11, warfarin is worst for stroke and worst for bleeding in renal failure. So, the ACC has recommended apixaban and not warfarin. The misnomer is warfarin is not exceeded, the kidney gives free. But the recent data suggests warfarin fares worst with kidney disease. Okay. So, if you have severe renal disease, we will not use warfarin, knowing that it is not exceeded to the kidney. The Canadian data, we will use apixaban, is approved by FDA also. So, that is the, if these agents are used with caution, the only limitation is financial constraint. But most of the young persons bear the financial constraint because they do not have to see what I am going to eat today. I have to go to the pathologist, then again to the clinician, and vice versa, and whole time my mind may not bleed if I injure, and so these are the biggest advantages.
So, definitely sir, you have rightly mentioned. This is just a last question for you, sir. You have 3 NOACs, apixaban, rivaroxaban, dabigatran. You have already mentioned dabigatran is certainly useful in this, apixaban is useful in renal. So, if apart from this any condition like is coming, like a patient has high risk of MI, patient is compliance preference. So, in such kind of the conditions, means in various kind of the cardiovascular conditions, how will you categorize these drugs?
See, everything is very simple.
Yeah.
There will never be head-to-head trials. So, you will say dabigatran is superior, what is the data? The data will never come. So, selection of these agents is very simple. If you have a patient who has a high ischemic risk and a low bleeding risk, means the ischemic CHAD score is high, bleeding risk is plus minus, or we will use dabigatran in higher dose, because if dabigatran 150 has the greatest power of reducing stroke. So, high ischemic risk, low bleeding, dabigatran 150. If you have a high ischemic risk and high bleeding, because most of the bleeding risk and the ischemic risk factors are same, then we will use apixaban, because apixaban the bleeding risk is minimal. The efficacy is just like warfarin. We will not use, or if apixaban is not available, we may use dabigatran 110. Dabigatran 110, stroke risk same, bleeding is less.
Yes.
So, suppose you have renal failure, obviously we are going to use apixaban. If you have a GI bleed, you will bank upon apixaban. If you have MI is a pseudo risk, actually the number of MI has never been, whole Rely trial 2 or 3 MI were there, but the number of patients who developed intercerebral hemorrhage, 50% of them are dead. Yes. So, where is the question of MI? Okay. Some nominal numerical increase was there, but somebody is, and CAD is not a contraindication of me. Yes. If somebody is scared, he can use apixaban. Rivaroxaban does not increase MI. If you have bleeding risk very high, CHAD score 3, 4, 5, rivaroxaban has been tested in that patient. Elderly, apixaban, because they are bleeding prone, they have renal failure. So, this is how can be easily selected, although there are no head to head, but this is a very rational and a logical conclusion which you can draw. Suppose my patient comes with severe renal failure, I am not going to use dabigatran, I am not going to use, I will instead of use apixaban. If patient high bleeding, high ischemia, I will use apixaban. So, things are, even in absence of head-to-head trial, you can easily choose the agent, and you can also reply why I am choosing. It is not that elderly come, I will use apixaban, I will not use.
Yes, obviously. It is not a hypothetical, but it is a very rational kind of answer.
We have the data that, so why using apixaban? Because the bleeding is risk, GI bleed, why using apixaban? Dabigatran increases the GI bleed, so that is why I am using. And then GI bleed is easily manageable for all practical purposes. Unlike the head bleed, intracranial, you will die. So, disadvantage with dabigatran, rivaroxaban, they increase GI, but apexaban does not increase. To some extent, it may decrease. So that is
So definitely, the Dr. Manoria said very well that is given very practical kind of the approach that how the VKs are available, but they have very wide kind of the practical issues like monitoring of INR, PT monitoring, food drug interactions, and poor compliance. And the NOACs can replace that, and even all out of all three NOACs, how the each and every NOACs can be selected for a single individual kind of patient, renal failure, high GI bleed, MI patients. So it's very well answered by Dr. P.C.
I think when should we use warfarin? Now, warfarin has to be used if you have a valvular atrial fibrillation. The neo agents are not suitable at the moment. If the patient is very poor, you have to use warfarin. If some patient is doing well with warfarin, suppose his INR is stable, no ischemic risk, no bleeding, you may continue risk, but keeping in mind that the intracranial bleeding risk is 50% more with warfarin. If the patient and physician interacts and then decide that this patient who is very well controlled wants to shift to neoagent because of fear of intracranial bleed, and that we finish if your bleeding risk is high due to some reason, then even if the patient is doing well, we will shift to a neoagent. Or you have a high risk of intracranial bleed, like a hypertensive patient in atrial fibrillation, we will not prefer warfarin at all. We will explain, because hypertension otherwise bleed, if you use warfarin they will. So, high intracranial risk bleeders, warfarin is not to be preferred.
So also this is a well taken point that in which conditions warfarin also can be used. Definitely it's a very low cost available molecule and it has the own advantage in valvular conditions and in other part. So thanks a lot